I'm asked to talk about something that I didn't really see how it necessarily fit into this meeting. Compensation. When it comes to translation, I didn't really see it. Nonetheless, it's something that's clearly near and dear to me. In addition to what Mark mentioned to you about me, I've been committed to working on guidelines for the care of both CRPS and just the treatment of the injured worker. Our former distinguished governor of California appointed me to what's called the Medical Evidence Evaluation Advisory Committee, a group of 12 physicians, to write guidelines for the medical care of the injured worker in the state of California. And the purpose of that is to try to be as rational as possible to make sure that patients with whatever injury that they have and whatever morbidity that they have as a result of an injury in the workplace are entitled to the care that they should get without physicians abusing the system by giving them far more care than is really necessary. And the problem we had in California preceding that was that many physicians clearly were abusing the system, and we had a pendulum that swung to the point where it was very hard for the injured worker to get any care, especially the CRPS patient. And so we were appointed about 6 years ago, and we did a very diligent volunteer job to rewrite the guidelines. So what I want to talk to you today about is 4 brief categories that I think are important if we're going to talk about compensation issues in the CRPS patient. The first one is the need for diagnosis. The next is a little bit talking about the whole process of guidelines, because I think, although not completely relevant to this meeting, the concept of guidelines should be understood by all of us who are participating either in care or research for the CRPS patient. And then I want to talk about the need for new treatment guidelines. And finally, I want to talk a little more about the process that we all work in as physicians to try to provide care, and what is the environment that we have in the United States and even elsewhere in the world with regard to how our procedures get approved and how patients are actually compensated and what major obstacles there are for treatment. Well, the first thing in CRPS that's important if you want to be compensated either in the courtroom for an injury that you received or in the medical arena to be able to receive the care that you need is that you need a diagnosis of CRPS. And CRPS doesn't have a gold standard like if you have breast cancer, you do a biopsy, you can tissue type, you have the histology, and bingo, you have a diagnosis of breast cancer, and you are entitled to whatever treatment your physician feels is appropriate for the treatment of breast cancer. I could go through a litany of different disease processes. Could I just get a little water here? Where there are true gold standards for the diagnosis. Unfortunately, CRPS does not have a biopsy, does not have a gold standard. What we have are diagnostic criteria. And in the United States, we mainly use 2. There's the International Association for the Study of Pain's diagnostic criteria for CRPS that several of us, Dr. Harden, Dr. Raja, myself, have participated in their development, and I feel that to date they are the best guidelines. Now, in addition, we have in the United States the American Medical Association's guidelines for the diagnosis of CRPS, and what I have to tell you is that not only are these guidelines outdated, in that they use things like triple phase bone scan as one of the diagnostic criteria, lumbar sympathetic blockade or stellate ganglion block as a diagnostic criterion, all of which have been thrown out by more educated people in developing guidelines. So the AMA guidelines are actually there to determine what kind of long-term disability compensation somebody should get if they have CRPS, and not necessarily for medical treatment. And they are written by people that the AMA has selected, and to my knowledge, and I could be wrong on this, but I didn't identify one person who I knew from the CRPS world as an active CRPS treater who specialized in it as one of the people who wrote those guidelines, mainly occupational health physicians who are normally employed by insurance companies and then have that bias. Now, I'll just give you a little aside. Whenever you write anything now in certain venues, you have to do a complete disclosure of conflict of interest. And that means pharmaceutical companies or equipment companies. And it's important for transparency that you do that. Unfortunately, the bias of working for an insurance company somehow gets excluded. And if you get lots of grants from insurance companies in the research you do, or you're employed by an insurance company to minimize cost, you don't have to reveal that bias when you sit on a guidelines committee. So we get this inherent bias. And so the AMA guidelines are made to scrutinize people to see whether they should get compensated in terms of long-term care, prostheses for the home, compensation for missed work, et cetera, et cetera. And in my opinion, given how many diagnostic criteria that they have in there that are outmoded, they're really not particularly useful. The ISP guidelines are well thought out and probably need to be updated given some of the information that we hear here and is in the medical literature since they were written. And it's hard because we have the issues of sensitivity and specificity every time we look to add or subtract something from the diagnostic criteria. And Dr. Harden, who's sitting there, is the maven of this, and I see him making facial expressions as I speak. But the important thing is that what we have to do as clinicians, if we want to get our patients compensated, again, either for the care that they deserve or for compensation in the legal system, is at the time of examination, we have to fully document all the pertinent positives and negatives with regard to the diagnostic criteria. And absent that, looking at many old charts, it's very hard to discern whether somebody really had the diagnosis or not, because a lot of physicians, and especially orthopedists and general practitioners, say, well, the patient has pain out of proportion to the injury. They had an injury, so they must have CRPS. But one of the things that the ISP diagnostic criteria have in it is it says that if you can explain the phenomena by other means, then that doesn't count as one of the diagnostic criteria. So a patient has a crush injury and the nerves to the foot are not working at all because of the crush injury. You can't count the fact that they can't move the foot, if that's the only movement thing, as one of the movement criteria. You need the kind of CRPS kind of movement problems that go along with it. So we really have to continue to optimize diagnostic criteria if we want to make a diagnosis and be able to sell to insurance companies or who's ever looking at paying the fact that the patient has CRPS. Now, yesterday, Dr. Getson gave a talk where he talked about using thermography, and that's clearly, temperature change is one of the diagnostic criteria. Although I think, is Dr. Getson still here, or he fled? Oh, he fled the scene. Okay, well, I didn't question him yesterday, but it's nice in a legal environment to be able to show exactly what's there, but I feel that if somebody believes the integrity of my examination and I demonstrate that there's an asymmetry in temperature, that is part of what I'm documenting, and in a good exam, a clinician should be able to do that and the physician should be able to be believed. Well, the second topic I wanted to talk about is guidelines for treatment. And the first thing I'll tell you is that most guidelines for treatment that are out now are outmoded. And when we look specifically at CRPS, it's incumbent upon the International Association for the Study of Pain, and we're looking at doing this, is writing new guidelines that incorporate the newer treatments that are now available that weren't available when the guidelines were written. Now, if you look at most of the guidelines that American insurance companies use, these guidelines were written probably at least 5 years ago. And much has happened in the last 5 years. Now, the gold standard in putting something in a guideline for treatment is that there's evidence-based medicine. And for those of you who are not clinicians, I'm not sure you fully understand what that is, but evidence-based literature has to be demonstrated. And that basically means the highest quality evidence-based medicine is randomized, placebo-controlled trials, double-blind, randomized, placebo-controlled trials demonstrating efficacy. And unfortunately in CRPS, there's not a lot of that. Now, one set of work that's been done by Robert Schwartzman, for instance, on ketamine, is now in the literature, where he actually has been very diligent in doing that and publishing it, and now there is true Class A evidence for the use of ketamine. Now, over the last 2 days, we've heard a lot of people in different contexts talking about the benefits of ketamine. I truly believe in it. At the same time, none of the guidelines have yet incorporated it, even though those data are there. Data are there, but the guidelines are old. So you speak to an insurance company about wanting to do ketamine, it's not in the guidelines. And you can send them all the great double-blind, placebo-controlled, randomized trials you want, and they'll tell you it's not in the guidelines. And if they're not thoughtful when they're doing the evaluation, the patient will not receive the treatment that they deserve. So I want to spend a minute talking about spinal cord stimulation, something near and dear to my heart, and CRPS. And I know there are some people in this room who strongly believe in spinal cord stimulation, and then there are some people who don't. As somebody who's been using it now for this syndrome for better than 15 years with a lot of great results, including the ability to take the stimulator out after the patient is better, I feel that it has its place when appropriately selected patients. In our center, we say the right procedure for the right patient at the right time. And it can be the wrong time, it can be the wrong procedure. But given that, there are some studies, there are numerous studies, most of them are not Class A evidence in the medical literature, and one that came out in the New England Journal, and if it's there, it must be true, like the National Enquirer. There was a study that came out of Europe where they looked, the Kemmler study, where they looked at spinal cord stimulation in what was called an intent to treat analysis. And in that study, patients were allowed to cross over from spinal cord, from conventional therapy to spinal cord stimulation. It was, the group was physical therapy plus stimulation versus stimulation alone. And over the course of the first paper that came out was positive for spinal cord stimulation. And then a letter to the editor came out in the New England Journal several years later that basically said that in their intent to treat analysis, there was no longer statistical significance between spinal cord stimulation and the non-receiving patients. The problem was that the way they analyzed their data, the patients who started out in the no spinal cord stimulation group and then crossed over into the spinal cord stimulation group were counted as non-stimulation patients, and they improved, so that there was a statistical artifact that then lost the benefit of spinal cord stimulation from a statistical standpoint, and the outcome was, or his impression, Kemmler's impression, was that you could no longer say that spinal cord stimulation had long-term benefit, even if it had short-term benefit. Now insurance companies use that. And in fact, this is a really, I think, an important anecdote. A patient of mine who was in a motor vehicle accident, in the coma for 3 months, woke up with CRPS in his right arm, completely debilitating to the point that with the medications he was on and the disability from the pain, he was completely non-functional and sat on a couch. He did functional rehabilitation with spinal cord stimulation, and now is actually a physical trainer, and I've replaced his stimulator, the internal pulse generator, on 2 occasions. Well, when it came time to replace it for the 3rd time, a physician reviewer from New Jersey, I'm always worried about the people from New Jersey who are reviewing me in California, a physician told me that he couldn't approve the spinal cord stimulator because the data shows that spinal cord stimulation does not have long-term efficacy in patients. I said, well, what about this patient who's been using it for 15 years and now is working and is starting to regress now that his battery has failed? And they said, well, I just go by what the literature says. And that's clearly a misinterpretation of the literature, and it actually ignored the guidelines that were written in our state that actually approves the use of spinal cord stimulation for CRPS in appropriately selected patients. This guy only needed replacement of an internal pulse generator. But I'm just giving you a little picture of the world that I live in on a regular basis. And I would say now, given the population that I have, I spend close to an hour, probably an average of about 45 minutes a day on the phone with insurance companies fighting for the care that my patients deserve. And I should put that in the context of the fact that, number one, I wrote the guidelines, so I know what needs to be in the medical notes. All my notes are typed, so nobody should have any trouble deciphering them. I have everything that they need in the notes, and yet I still have to have these conversations with these people on a regular basis. I don't feel it's a good use of my time, but in the world I'm living in, absent doing that, the patients don't get care, and that's really necessary. Well, given what we're here, well, let me just talk, okay. Given what we're facing now, I think there are new treatments that have come out, and at least 2 of them, and there are actually more that need to be commented upon. And so things like ketamine need to be incorporated in the guidelines. Things like IVIG and where it should or should not be used should be incorporated in the guidelines. And right now, no state in the United States and no insurance company has either of those 2 therapies, and there are others. So it's time to convene a group of international multidisciplinary experts to look at the evidence and come up with a new treatment algorithm or a modified treatment algorithm for CRPS. Well, I've tried to give you a perspective on the compensation world. I just want to mention a few other things. I kind of gave you a picture of the insurance companies and how we have to deal with them. I want to emphasize one aspect. There's a group in the United States called the American College of Occupational Environmental Medicine, ACOEM. And they write guidelines. They're for-profit guidelines that are written so that insurance companies can then use them to administer to save costs. And their guidelines are, quote, evidence-based. Yet they don't really hire people to look at writing the guidelines who are treaters in the field to a large extent, mainly written by occupational physicians who are employed by insurance companies. And we've had a lot of back and forth with them on how they do things because they choose to throw out data if they don't like where it came from. And it could be, for instance, data that have been generated by distinguished colleagues like Richard North, who neurosurgeon at the time at Johns Hopkins, doing randomized control trials, and yet because he received some funding from industry to do his study, they threw out all his work. And so then they're left with whatever literature is there that didn't get funded by industry. When you want to determine whether spinal cord stimulation is effective or not, it's very hard to do such a study if there's not industry support. And that's just a reality. It's expensive to do those kind of randomized studies and then to do the analysis and get them published. If it's in a journal like neurosurgery or pain, you can be guaranteed, or guaranteed may be a strong word, but you should be assured that the people who are reviewing have an eye for any kind of inherent bias and they'll throw out a study that isn't quality study. But anyway, the ACOEM people throw out the studies and then you're left with the opinion of the people who are writing the guidelines, and these opinions are biased opinions, again, that may not be fully disclosed. So we're forced in some states to actually work with those kind of guidelines when trying to treat patients. And it can be very challenging to do so. Unfortunately, Dr. Getson's not here today because I wanted to talk about a common experience that we had. I work for a group called Best Doctors. They're out of Boston, and they are a group that look at catastrophic medical cases and try to determine a best solution for the patient after usually $250,000 have been spent on medical care. And Best Doctors basically gives me free rein to comment on anything that I want. And there was a case of Dr. Getson's before I ever met him, and we actually talked about that, where he had diagnosed CRPS, well documented in the chart. Dr. Robert Schwartzman diagnosed CRPS, and two other people who I know who have decent reputations in CRPS diagnosed it. There was a physician in Philadelphia who doesn't practice medicine, who examined this patient and said there were no signs of CRPS, both before and after, and then once again before and after the treating physicians had examined the patients and fully documented diagnostic criteria. This person's paid by the insurance company to minimize care. And the insurance companies do that in this country. I do some reviews for insurance companies because I feel that it's very important for people who treat to do honest evaluations. And I'll just give you one anecdote. The drug Actic, or oral transmucosal fentanyl citrate, is FDA approved in the United States for the treatment of cancer pain. And that's the way it mainly should be used. But there are occasions where it has a place outside. And I actually strongly believe that when it's not being used properly, it should not. And so one carrier hired me to do reviews on this drug. And 6 consecutive reviews, I felt it was inappropriate. And then the 7th patient came. The patient had severe pancreatitis, acute, superimposed on chronic. And to keep the patient out of the hospital, the provider had been giving small amounts of this drug when necessary. And I felt it was okay. I never got another request to do a review of that drug from the insurance company once I approved it for an off-label use. And that's the system that we work in. We work in a system where we have ACOEM guidelines, and I want to mention parenthetically that the RSDSA, when it came to the ACOEM guidelines and how they were being constructed in a way that was not favorable to the patients with CRPS that deserved care, the advocacy of the RSDSA made comments, and there was a lot of back and forth. And I'm not sure that it really had much impact on them, but at least we're on the record. What I tried to do here is give you just a little bit of a context of the compensation world for the CRPS patient. It's very difficult to get authorization for the patients who have CRPS a good part of the time. It's incumbent upon all physicians to document all the signs and symptoms and to also be advocates and participate in the process as much as possible. Thank you very much. Do we have time for 2 questions? Norm.
I've spoken to those doctors in New Jersey, in fact, recently, on a Sunday, who denied care to a patient with CRPS, care that's typically used. And as an expert for the medical board, I think it's incumbent upon all of us to realize that they are, they need to follow guidelines, and the medical board could investigate them if their names were reported. And I think it might be helpful to collect names of doctors in New Jersey who refuse standard care to patients, and keep a note of this and allow the medical board to be aware of them.
Dr. Getson and I had that exact conversation yesterday.
It works. I've testified against some.
Well, first of all, thank you for not volunteering me to be a part of that placebo-controlled study of parachutes,
Okay.
which you usually do when we start giving this back and forth about spinal cord stimulators or not. But we shouldn't do that today. I think we can, we start with the apologia. We don't have good evidence, and the Kimmler study is highly flawed on many, many, many levels, so we just simply don't have any evidence for many of the things that we do. So, that apologia aside, we still have to treat patients. We still have to have guidelines. We have to develop guidelines in the absence of evidence. So I guess what I need to get out here is that you and I may disagree about many things, but I think we certainly agree on the fact that we simply need better research. We need somehow, some way to find the money and the energy and the enthusiasm for doing the research so that we can develop an evidence-basis, sort of a structure and a springboard for guidelines and rules and who gets what. But the apologia aside, I take it very personally when I look at the literature, as Roberto caused me to do when he did his brilliant systematic review, and there's nothing much. I mean, the things that come out that survive the systematic review are really kind of off the wall. And the things that we do traditionally to treat the disease, and I'm going to call it a disease, are not included because there's no evidence. So, this is a tough nut to crack, and the apologia, and we're developing a practical guideline, meaning we're going to make a guideline based on everything, including anecdote and what you've learned. But it doesn't remove the responsibility. It doesn't change the embarrassment we should all feel as researchers in the field that we simply don't have that evidence. So, sorry, that's my little epistle there.
Thank you.
Maybe a small addition. Thank you for the nice presentation. I think what we should look at with guidelines is a way to establish a kind of baseline to look at what we need to establish, what kind of additional research we need, and properly define guidelines within the framework of the country where they have been developed, because of course you have additional considerations with regard to the organization of care, which is different in the Netherlands than it is, for instance, in the UK or here in the United States. I'm sorry. So you need these things to be taken into consideration, but properly defined, you can use it by then to then establish your research agenda. And that's a nice thing to do here, actually, if you're planning to update your guidelines, to use this maybe for our next session to look at where do we need additional information, what's required, and build on that and start programs directed towards research in these areas. That would be my advice.
Thanks, Joshua, for a great presentation. Carol Robertson-Plew, I'm with Eli Lilly, a pharmaceutical company. And just further comments on guidelines and other things that are needed in order to move molecules forward for a specific indication, such as CRPS. We need guidelines so that we can appropriately select the patients for a study, a clinical study, so that we can prove to the medical community, but also to the FDA, to the EMEA, to all of the regulatory organizations that we work with around the world, that we have selected the appropriate patients, and that there is a way for physicians to select these patients that would be treated with the given drug. In addition, recently, over the last couple of years, actually end of 2009, the FDA released a guidance document around PROs, which is patient-reported outcomes. And that means any kind of a scale that, or a measurement that would be reported by a patient on how they have improved. Well, the FDA has set new guidance on what needs to be met to qualify a scale as being a validated PRO, a validated patient-reported outcome scale. And it's substantially, it's going to take effort and research to develop those PROs and to demonstrate that they're validated. And it's through organizations like IASP and RSDSA that these kinds of things can become available. And as those things become available, it becomes easier for pharmaceutical companies, and maybe not so much easier, but it becomes more possible for us to move forward with projects looking at certain diseases like RSD, such as complex regional pain syndrome. So just a couple of plugs there for...
No, I think that's really relevant here, and just to add on to that, and not to steal Norm's thunder here, but in 2003, a group met, ISP group met in Budapest, and what Norm called proposed amendment or new proposed diagnostic criteria that amended the ISP's early 90s diagnostic criteria for CRPS into two groups, the research criteria versus the clinical care criteria. And the clinical care criteria far more sensitive in picking it up, but less specific. But if you're doing research, you need much tighter diagnostic criteria so that you want to be sure you have closer to a pure group of CRPS, so they are far more stringent, less sensitive to picking up the disease, so you'll exclude some, but it doesn't matter when it's research, but more specific, so you're not throwing in other people who don't have CRPS. And so we have these two research versus clinical criteria that we use, and the research ones clearly are intended for exactly what you're talking about.